Good morning, everyone. Welcome to the spinal cord injury lecture series for primary care. My name is Viet Vu. I'm a physiatrist at GF Strong and Vancouver General. Today, I will be talking about the neurogenic bladder in spinal cord injury. We're holding this talk in Vancouver in the lens of the Squamish, Tsleil-Waututh, and Musqueam nations. I have no financial support for this talk in terms of industry funding. And the faculty that helped organize this is Dr. Andrea Townsend, Dr. Robert Petrella, and Dr. Janice Ng. Mitigating some potential biases, you could review this, but this is pretty standard across the talks. So our learning objectives for this talk, we should understand the anatomy and physiology, which I'll review quickly, and then describe the differences between an upper motor neuron bladder and lower motor neuron bladder, stuff that we learned back in the days of medical school, and then describe the best practices for bladder management, understand the recommendations for screening, and then understanding the complications of urinary tract infections, stones, and bladder cancer. I'll spend a lot more time on UTIs. So question number one, what percentage of SCI patients have bladder dysfunction? It's high. So up to 80% of spinal cord injured patients have bladder dysfunction. And it's important because it's the number one cause of re-hospitalizations. When in doubt, always rule out UTIs. The second number of hospitalizations is respiratory issues such as pneumonia, namely aspiration pneumonia and even community-acquired pneumonia. And then third is the pressure injuries and skin breakdown. We, as non-spinal cord injured patients, do go into the bathroom for granted because it's autonomic or automatic. So people with spinal cord injuries have to think about when, how to empty their bladders, and then it needs regular reassessments. So let's go over what micturition means and why it's important to have controlled volitional emptying and storing of your bladder in a socially accepted manner is what gives adults the ability to urinate when it's appropriate versus infants and toddlers who don't have the cognitive control of micturition. Which brings us to the anatomy. I think it's important to understand when we talk about the GU system, the upper tracts, kidneys and ureters, and then the lower tract, because we focus mostly on the lower tracts, but it's really, we're trying to protect the upper tracts from damage, because 50 years ago, the number one reason that spinal cord patients would die was due to renal failure. And then lastly, the neural control of micturition. With all that's happening, you know, it is autonomic, but there is input from the brain. And so all of this is altered when somebody sustains a spinal cord injury. Upper versus lower motor neuron. If you remember neuroanatomy, the spinal cord ends at between L1 and L2, and then below there is the cauda equina. So above the cauda equina, or where the conus is, injuries above there is considered an upper motor neuron bladder, or it's called a reflexive bladder, spastic bladder. So those are the suprasacral lesions that also lead to something called detrusor sphincter dyssynergia, where it's very coordinated. The sphincter has to open before the detrusor muscle contracts, so that urine can follow through and be excreted. When detrusor sphincter dyssynergia takes place, both muscles contract at the same time and there is no outlet, so there is an obstruction there. So that happens with an upper motor neuron bladder, whereas the lower motor neuron bladder, everything is flaccid. The bladder capacity is way higher than normal, but also the sphincter can be flaccid. So you could see it demonstrated down at the bottom. So this is a spastic bladder, and you could see how it's there's diverticula because of the high pressure, and it's a very small capacity bladder when it's filled. And this is a flaccid bladder, and you could just keep filling it. The pressures will not increase. And these two distinctions are important because it helps determine the bladder management. The goals of bladder management are continence, basically avoid incontinence to protect the skin and hygiene. And then regular bladder emptying, which is between 4 to 6 hours. You don't want somebody having to empty their bladders more frequently than that or less frequently than that. And then to avoid increased bladder pressures, this applies to the upper motor neuron bladder. And then avoiding complications and preventing complications. And ultimately, to maintain a regular lifestyle so that you're not always focused on emptying your bladder. So the best practices are either having an indwelling catheter, there's two, a Foley catheter and a suprapubic catheter. And the non-indwelling is what's called clean intermittent catheterization. And then at the bottom, I lined this out because we don't recommend condom drainage anymore, and I'll go through that in detail in a little bit. For an upper motor neuron bladder, for tetras who don't have hand function, we would recommend an indwelling catheter, either through a Foley catheter or a suprapubic catheter. For paraplegics with good hand control, we would recommend clean intermittent catheterization. For those with the cauda equina or lower motor flaccid bladder, we would recommend clean intermittent catheterization with the use of a condom drainage catheter. Condom drainage just in between, because if you think about it, the sphincter is open, and so with any abdominal movement, increase in abdominal pressure, a little bit of urine can come out. The difference between a Foley and a suprapubic catheter, it's the same system, it's just that the size of the catheter is smaller in the Foley because it's limited to the size of the urethra. Whereas the suprapubic catheter, you can go, typically we start at 16, but we go to 20, 22 French catheters, and it just helps to drain the sediment better in the bladder. There is a procedure that's involved with the suprapubic catheter placement. It's usually done under fluoroscopy through interventional radiology or cystoscopy by urology. Again, the advantages of a suprapubic catheter long-term is that it improves the flow of urine. It has also decreased episodes of autonomic dysreflexia. It frees the penis for sexual activity. Some of the disadvantages is that it can also, in the beginning, have urethral bypassing just because urine is just so used to coming out through the urethra, through the Foley. Secondly, the first change, so once the suprapubic catheter is placed, you have to wait 6 weeks before it's even changed, and the first change needs to be done by urology. And then it is reversible because the stoma closes quite readily. Like if you don't have a new system ready to be placed, sometimes the stoma could close within an hour. And then at the very bottom, don't forget a stat lock. It's a device used to secure and anchor the Foley catheter. A lot of our patients use Velcro leg straps as well, but they're not as sturdy as the stat lock. What's next? Clean intermittent catheterization. This is when someone has good hand function, they're able to do this cleanly. It doesn't need to be sterile. They start off every 4 hours, and then they can stretch it to every 6 hours depending on their water intake. The target volume of catheterization is about 500. In the mornings, it can be higher. Fluid intake has to be really managed so that they don't overwhelm their bladders. Just to be aware that overnight, because they spend most of their time in the wheelchair, that when they go to lay down, there's a lot of dumping at night, so their bladder volumes may be a lot higher. This is the most physiologic way of managing your bladder after a spinal cord injury because it allows the bladder to expand and contract. Some of the cons are the urethral trauma. Sometimes because people are insensate, they can create false passages that needs to be examined by urology. Lastly, it's also expensive. We don't recommend reusing the catheters. Unfortunately, the inside, the lumen of the catheter just cannot be cleaned well enough, despite all the attempts to clean the catheters. And then I want to say 40, 50 years ago, even people were using condom catheters after a spinal cord injury because they didn't want an indwelling catheter. Every day, a condom catheter would be on and it would break down the penile skin. Other complications were urethral fistulas on the outside, but what we couldn't see on the inside was the buildup of pressure in the bladder. And so people would have high post-void residuals that would increase the detrusor pressure, lead to autonomic dysreflexia. And then urologists were doing what's called a sphincterotomy. They cut the internal and external sphincter so that it would just drain in the bag. But it was unbeknownst that the tone would come back into the sphincter, and people would have to do this at least 3 times before it fully opened the sphincter. So people needed really close monitoring of the bladder pressure. So we don't do this anymore. There are still a few people who've had sphincterotomies and only use condom drainage, but for acute injuries now we do not recommend this. This is what I really want to impress on you is ongoing screening for kidney and bladder function. So this is annually. What you could do is order labs. We ask for eGFR, creatinine, and the new lab is the cystatin C to show bladder kidney function. Secondly, what's easy to get is a renal ultrasound. They'll check for the kidneys and bladder to rule out hydronephrosis and bladder stones. And then lastly, for complicated, recurrent urinary tract infections, we ask that you refer to urology. Actually, you should refer to urology on an annual basis. They just need to see and talk to a urologist, and then the urologist can triage if they need a cystoscopy or urodynamic studies. So cystoscopy, we normally do this 3 months after the initial spinal cord injury just to get a baseline study. And then what it is really good for is to evaluate the anatomy. It's a camera through the urethra into the bladder. They look at the bladder wall and look for tumors and stones. The frequency, again, the guidelines keep changing, but if somebody has complications with their neurogenic bladder, I would recommend an annual screening, and then especially if they have an indwelling catheter, such as a Foley or suprapubic catheter, they should be getting the cystoscopy once a year. Complications, there are a lot. Bladder and kidney stones, some people are just stone formers. We haven't figured out how. They could be the greatest water drinkers, but they form stones. So it's really important to, review diets with them. Second is urethral erosion. There's something called traumatic hypospadias, which you can imagine just splaying the urethra through the penile tissue. Urinary tract infections, which I'll go into in depth later, and then epididymitis. Incontinence, there's bypassing of the urine. Hydronephrosis, it sounds contrary that if you have a Foley catheter, it should be always draining, but sometimes the bladder can spasm enough that it increases the bladder pressure to lead to hydronephrosis. Over decades, there's a lot of fibrosing and scarring that happens in the bladder, and you could see this is a fluoroscopy of a Christmas tree bladder because it's so fibrotic that a lot of what's left is just the trigone, and then you could see the diverticula pooching out here. And then bladder cancer, and it's not the typical transitional epithelial, it's squamous cell carcinoma. This should be a discussion for people with indwelling catheters, the risk of bladder cancer. It does and can happen with prolonged, decades-long use. But again, the demographic of our patients, it's bimodal. We've got the young men who have injuries, for decades thereafter. And so if they are tetraplegic and they need an indwelling catheter, this is a real risk for them. It is super important just to get the cystoscopy done with indwelling catheters. And then the indications, the urologist will want to know if there's ongoing hematuria with recurrent urinary tract infections. It irritates the bladder wall. Hematuria is one of the manifestations. Again, recurrent UTIs. Asymptomatic bacteria, I can't say it, sorry, from stone-forming organisms. Proteus is a huge one. And then anytime you have sepsis with pyelonephritis, warrants a referral to a urologist. And then even if somebody is, has been using an indwelling catheter and they have recovered hand function and want to trial clean intermittent catheterization, this is a good time to send them to a urologist. And then the second study, which is really important to help us identify the best bladder management strategy, is a urodynamic study. And this is when they go to the urology clinic. There are catheters that fill the bladder with saline, and then they check the pressure in the rectum, which is the abdominal pressure, and then the pressure in the bladder, which is the vesicular pressure, and then they get the difference and find the detrusor pressure. Why this is important? Bear with me. So the detrusor is really magical in that the ureters, when they enter the detrusor, comes at an angle. So as the bladder fills, the valves close, and that protects the ureters from backflow. But it could only withstand so much pressure. So if you go beyond 40 centimeters of water over years, those valves become incompetent, and then that leads to reflux. So this is the only study that helps us to understand the pressures within the detrusor. And then lastly, for upper motor neuron bladders or the spastic bladder, we do use a lot of medications like antimuscarinics, old school oxybutynin, tolterodine, Vesicare, and then alpha-1 blockers. This is usually for those who say, they have a hard time starting their stream. So we'll use tamsulosin. The newest one is mirabegron. It's a beta-3. Fewer side effects of like dry mouth and constipation, but it is quite expensive if people don't have coverage. And then lastly, Botox. Botox is really, really good for bladder spasms. It lasts for 6 months. They use 200 units of Botox, and we could also use Botox for muscle spasticity. And then we just work with the urologist to make sure we don't go over the recommended dose. And then I just put a note at the bottom that the alpha-1 agonist can cause hypotension, so I tend to give it at night. So question number 2, what is the definition of recurrent UTIs? A, 1 episode per month. B, 2 episodes in 6 months. Or C, 3 episodes in a year. And I think you'd be right if you said all 3, all of the above, if A was for a minimum of 6 months. It's not that many, 3 a year. I know patients who have sometimes 3 a month, and it should be a cue for reevaluation. Why is this important? It's, UTIs are the #1 reason for re-hospitalizations. And because people have neurogenic bladders, they are at risk for UTIs. Again, it's a secondary health complication and adds to the morbidity and mortality of spinal cord injury. Along with neurogenic bladder, a lot of people use catheters for bladder management, so that puts them at risk. Diagnosing a UTI, it's not just the urinalysis cultures and sensitivities. We really want to see clinically what's happening. Fevers and chills, classic, but people just don't present the same way. They don't have the dysuria, they don't have the cramping. What they will show up with is my spasms are worse, or I'm getting AD and I can't figure out why. I'm not constipated. My bladder, I'm having bypassing and I never used to have, urinary incontinence. Or simply malaise or just malodor. I've had somebody had shortness of breath and we were working them up for pneumonia, but it was really a UTI. And then this goes hand in hand. If you can please get a urinalysis, culture and sensitivity, because we look at pyuria, bacteriuria, and cultures. And I'll go over an example of a recent UA. Question number 3, what is the best way to obtain a urine sample when someone has a Foley catheter? Do you get it from the leg bag here? Do you get it from the disconnect the leg bag and the Foley and get the sample there? Or do you need to remove the existing Foley and put in a new Foley catheter and get it from the new catheter? And I hope everyone is thinking C, getting it from a new catheter. Because more often than not, if patients go to Life Labs to get a urine sample, they simply just unlatch this and then obtain the urine sample. But you would have to understand that this Foley catheter, whether it's been in for 1 week or 1 month, there's a ton of bacteria that can grow even from this lumen here, much less the bag that's been there for a long time. So what we really want to know is what bacteria is growing in the bladder. I think we have to really consider how is this done in the community, and I don't have an answer for that because it's dependent on when the community, the home care nurse goes in to change their indwelling catheter is when they can get the new sample. But if a UTI creeps up, how do they navigate that? Okay, so this is a real urinalysis from a patient recently. You could see April 17th, the urinalysis was essentially normal or negative. And then April 30th, it was positive, and I'll go down with you what I tend to look at. Specific gravity is a really good number. In my mind, I think of 1015. 1.015 is the normal. So this is pretty close. And you could see back in April 17th, he was pretty diluted. He's a good water drinker. And then leukocyte esterase. So this is the pyuria. It's moderate. It could be large at times. And then nitrites, bacterial breakdown is positive. I also look at pH at 8. That means it's basic, alkalinic, and that's due to urease producing organisms such as Proteus. And then I look at, and you can see hemoglobin is large because, again, the irritation to the bladder wall from the bacteria. So this is one component that flags, yes, there is pyuria, and there is an immune response in the urine. So if he's stable, I tend to wait for the culture results. But if, he's spiking a fever, spasms are, unbearable, I'll start empiric treatment right away. If not, we wait to see the culture. And what the culture, it'll come out 48 hours after the urinalysis. But this is important. This is what I look at is the organism, and it should be greater than 100 million, and this is Klebsiella, and then organism 2 is 80 million of E. coli. The sensitivities, they break it down to organism 1 and 2, and you could see Amox is, both organisms are sensitive, ampicillin, it's resistant, and then Cipro, sensitive and resistant, Septra, sensitive and resistant. So clearly, we would then choose Amox and Clav, which is a good first-line empiric antibiotic for most folks. And then I would treat for 7 days, not 3, not 5, not 14. So if left untreated, of course, people can manifest autonomic dysreflexia if they are at risk for it. Sepsis and bacteremia is not uncommon. And then other complications, such as even skin breakdown, because now they're incontinent of urine. So the key recommendations is to really maintain a level of suspicion for a UTI, because people just don't present the same as those with non-SCI symptoms. For people with spinal cord injury, they can have autonomic dysreflexia. This is the headache, sweating, flushing phenomenon, increased muscle spasms. And then, like I said, respiratory, they can become short of breath just because I think they have an active infection. GU, urinary bypassing, malodor, general fatigue, fevers and chills, and then GI with nausea and vomiting. Basically, if your spinal cord patient presents to you with any kind of concern, I would rule out UTI. And then the SCIRE project, I hope everyone is familiar with this, has a really good algorithm of everything we've covered today. And then when to refer, again, 3 UTIs per year. It doesn't sound like a lot, but it's usually more than that. And then what we do is make sure they don't have bladder stones, because the bacteria can hide out in the stones, and they'll need to see urology for a cystolithoplasty. Make sure that they don't have an upper tract dysfunction. This is where the renal ultrasound and urodynamic study can come into play. Make sure they don't have the kidney stones or bladder stones. And these are all kind of interconnected, so there could be arrows in every direction. If they have hematuria or trauma, it's not unusual to have strictures or false passages in the urethra. And then again, if they want to change their bladder management, it's not unusual after a decade or two to go from a condom. Maybe they left rehab using a condom catheter, and now they figured out that their bladder pressures are high and are willing to use clean intermittent catheterization or even an indwelling catheter. We're nearing the end. The takeaways that I would love for you to consider is most people manage their neurogenic bladders using catheters, whether it's indwelling or intermittent catheterization. Secondly, the lack of sensation. Again, just always have urinary tract infections in the back of your mind for patients with spinal cord injury. This is the #1 issue that they encounter that require hospitalization. Annual screening, ask how they empty their bladders, and then if folks are happy with it. But if not, again, there's always opportunity to change the bladder management if it's not going well. And then refer to urology for cystoscopy, especially if somebody has an indwelling catheter. Other studies like urodynamics and renal ultrasounds can skip years once things have been stable for, I would say, like the first 5 years. What can you do as primary care providers? Download these checklists, go on the SCIRE website. We're trying to make it more accessible. There are videos on YouTube. This talk is being recorded as a reminder. And then again, this is how it looks like on the website, and this is how the primary care chapter looks like. Okay.
Thanks so much, Viet. EM has a question. Her question is, how is urine sample from someone with spinal cord injury typically done in the community? Presuming you aren't doing a urinalysis in asymptomatic patients, basically the decision to treat is based on a presence of NITS, HB, and then positive or minus increase in Lukes versus baseline, since they will all be bacteriuric chronically. I always struggle with antibiotic stewardship versus not missing the boat. Like, did you not sleep well, or is this a UTI, or is it a cold, or is it a UTI?
No, you are not doing urinalysis on asymptomatic patients. The decision to treat is based on the symptoms and the urinalysis, because nitrites can sometimes be negative, even hemoglobin could be negative. So it comes down to leukocyte esterase and pyuria and the symptomatology.
Yeah, I mean, I guess like the thing is that it could always be a UTI because the symptoms could be so vague, and they're always going to have bacteria in their urine. So I'm like constantly getting calls. I have a particular patient I'm thinking of who resides in long-term care, and like the long-term care nurse is like, you know, it's raining outside, we better do a urinalysis or like whatever. And she's got the added complication of having ESBL E. coli, so she's like
Colonized.
Yeah, well, but yeah, so treating her requires inpatient, like move to hospital because you can't just give her oral antibiotics.
Yeah.
So I'm like forever saying like, let's just give this a day, let's just wait this out, blah blah blah. Because she sort of always seems to have Lukes in her urine, and she always has bacteria in her urine, and always will because she's got the chronic indwelling catheter.
I would suggest going one step upstream and just making sure that the nurses are changing. I'm assuming she has an indwelling catheter of some sort.
Yeah, it's a suprapubic though, so the nurses are. It depends on the nurse you get.
Oh, it shouldn't. It should be protocol. I know.
I agree.
I even at GF Strong, we have to remind people, like, even unless it was just changed within the last 24 hours, she will need a clean sample unless they insert a catheter through the urethra to get a clean catch. But anything from the existing catheter is going to grow a gazillion of everything. So
Yeah,
you'll get a
exactly.
mixed flora, which is not helpful. Then you're just, then it's all just empiric treatment.
I guess I hadn't thought about doing the clean catch through the urethra with leaving the suprapubic in place. That's a very smart idea. Thank you.
You're welcome. And, my take, what I tell the residents is my go-to is amoxiclav, just because, unless they have a penicillin allergy, but that's, fairly broad-based treatment. And then I reserve the Cipro for really complicated UTIs because it's such a good antibiotic. I don't want people to become resistant to it. Septra I try to avoid because people have unknown sulfa allergies. But again, it really depends on the culture and sensitivities. That's why it's really important to get all three, the urinalysis, culture, and sensitivities. And then you could give the prescription for antibiotics afterwards.
Viet, sorry, and you and I have had those discussions where you really emphasized the sequencing and how important it is to get the sample.
You don't want antibiotics on board. People used to take macrobid as a prophylaxis, and they swear by it when it works, but then it really muddies the results of the urinalysis and culture. So we don't recommend that either. And then, macrobid is not benign. Long-term use of macrobid can lead to pulmonary fibrosis, and we don't want that in like a tetraplegic patient who already has restrictive lung disease.
EM follows up with, sadly, my patient has allergies plus ESBL, so it's ertapenem or meropenem every single time we treat.
Okay, I'll share my special request with micro. I usually call micro up and say, can you check if it's sensitive to fosfomycin? And fosfomycin is a really good one that I reserve for Proteus especially, and it's not a one-time shot for simple cystitis. It's a 3 dose, but it's every other day, 3 grams every other day, so it's almost like a total of 7 days of treatment.
Dr. Beamish, can you unmute?
So my question is the minimum number of colony-forming units to diagnose a UTI, is the threshold higher in a spinal cord injured patient versus the general population, or is it the same?
I use 100 million CFUs per mil because I think the idea is that we know they're colonized, right? But again, if they're symptomatic and it's 80 million, I'd still treat. And then Keflex, I think Keflex doesn't cover gram negatives as well as compared to amoxiclav, but don't quote me on that. I just don't tend to use Keflex, and I'm looking at Dr. Townsend, who's shaking her head. Yeah, we don't use Keflex. That's more of a superficial skin treatment in my mind.
Okay, that's very fair. I think I just saw on your sensitivities there that it was sensitive to cefazolin, so ANSA. But in any case, I was just curious because it seems like we're waiting for these systemic symptoms to manifest, fevers or chills or abdominal pain or sweats and this type of thing, autonomic dysregulation, in the spinal cord injury patient. Are we, and obviously we're not treating the asymptomatic bacteriuria, as you made clear, which is great. But are we just somehow missing then, in a large number of cases, the in-between situation, like a bladder infection before it gets to become a more systemic, kidney infection or urosepsis
Yeah, welcome to my world, because it's, these folks, I would say almost 100% of folks at GF Strong will have a urinary tract infection, right? And so their exposure to antibiotics is insane. We do want to minimize the antibiotic exposure, but then people become septic bacteremic pyelo in 4 hours. Yeah. So really it's based on the symptomatology. I think folks in the community know how bad it is, and they'll say, I'm gonna ride this out or try to flush it out. I'm gonna load up on my vitamin C. They've got lots of tricks and tips to avoid taking antibiotics. You know, back during training, I was taught to flush with antibiotics into the bladder, and now we're not taught that anymore. So I think some folks in the community still practice that, and it does stave off the UTIs.
Okay. And do other simpler things like drinking more water, hydration, or cranberry juice or this type of cranberry pills,
Yeah,
anything like
oh,
that?
the Canadian Nursing Association dispelled the cranberry myth. So that's not recommended anymore. But again, some people swear by it. I'm not going to discourage them. I would encourage cranberry supplements over juice to avoid the sugar intake. But people take vitamin C. Some people do D-mannose. Some people do apple cider vinegar as ways to acidify their urine. There isn't great evidence. There isn't
Fair
great
enough. Thank
evidence.
you so much. That's super helpful. Thank
You're
you.
welcome.
Dr. Vu, thank you very much for this excellent and comprehensive presentation.
Thank you.
I have a question about bladder stones. Typically, will they be symptomatic, increased spasticity, change in bladder function?
Yes, to all of those, because I think if you're a stone former, it just becomes problematic. I recently had a young patient who drank a ton of water. It wasn't his problem. He just formed lots of stones, and it would block the Foley. You know, there's eyelets at the end of the Foley catheter. It would block it. And when we sent him to urology to do a cystoscopy, he had so many stones, he had to come back for a second procedure to collect all of the stones. So you could imagine all the different size stones will block the eyelets of the catheter. No one's really figured out who are the stone formers and if they could change their diets. We went through, like, you know, avoid nut milk because it can be an oxalate producer. And mom was really diligent, but he was infection after infection because he is just a constant stone former.
So typically it divides out into stone formers or non-stone formers. So if somebody's hasn't had evidence of stones for many years, it would be unlikely that they would
Typically, yeah, they would present themselves pretty early. I think the young guys too generally have hypercalcemia, and that could lead to stone formation. In the beginning, it does level off in time.
That's good to know. Thank you.
Okay.
We've got another question from Astrid. She says, is it possible for a person with incomplete tetraplegia to regain bladder function? Is it common or is it rare?
I took this out, Astrid, because I was trying to shorten my talk. There is a prognostication for incomplete tetras. When we're talking about incomplete tetras, I'm thinking of the patients with central cord. They have really impaired hand function, but good leg function. And the idea is if they're the nerves in the lumbar spine, if you could picture the spinal cord, and then the lumbar nerves, and then the sacral nerves below. So a multi-center, like European study, looked at the lower extremity motor score. So, you know, manual muscle testing of the legs. If they generally have 4s and 5s, that's a good indication of possible bladder function recovery. So that's when we would do something called a trial to void and see if they can urinate. But yeah, thank you for that question.
I had a question, Viet, if you don't mind. You and I have talked a bunch about this, but if you could tell GPs what is it that they can do to best interact with the system and sort of help physiatrists as well as helping their patients. Like, what are your number one recommendations for GPs in primary care?
I think if we're focused on the bladder, just definitely make the referral to urology. And I totally understand that not all urologists like or practice neurogenic bladder management. I've had to really make a case for a patient in the interior that he needed a urodynamic study. If somebody comes to you, you know, a quick question is, when was your last urology visit? And they say, I don't remember. that would be a good time to refer them to urology. If you're in the Lower Mainland, the Blessin Spinal Cord Center has urologists who focus on spinal cord injury and neurogenic bladder. We do have lists throughout the province of urologists who do even intravesical botox, urodynamics, and cystoscopies. That should be standard fare for urology. And everyone should have access to a urologist, although they do need a referral from their practitioners.
Andrea has a question.
I just thought you might want to comment on the annual creatinine and how a low creatinine is normal and even a below normal creatinine is normal, and as soon as it's creeping up.
Thank you. Yeah. So we do check creatinine every year, and you just have to, I think we just accept that it's going to be normal and low normal in the tetraplegic patients. But it's not really just that one snapshot. We're trending this, right? Like you want to trend it just annually to see if it increases over time, and that's when that should raise suspicion. Otherwise, there really isn't a great, again, and then we follow eGFR, creatinine, and hopefully we could start testing cystatin C. It should be relatively easy.
Does the delta creatinine make a difference? So if someone has been chronically low for a long time and then comes into what would be considered a normal range for them, but is, let's say
Exactly.
20 or 30% higher than their normal, like are they considered, like, do I need to start renally dosing their meds now, or do I still use normal eGFRs for that?
You're killing me. No, there is no published delta that we are aware of. It's just monitoring if there is a delta. Basically an increase. But again, I'm hoping that it's the full picture of renal ultrasound to make sure. You're kind of late to the game if the renal ultrasound shows up with hydronephrosis, right? So then the cystoscopy, just because we cannot see inside the bladder, and then the urodynamics, just to maintain that we know that the bladder pressures are okay. Because it could be elevated at 60 centimeters of water, but if it's been like that for years and years, they may not have to change their bladder management. But all of a sudden, in the course of 3 years, their bladder pressures have gone from 40 to now 100. We really have to encourage them to change their bladder management. So it's the whole picture, not just creatinine.
So Dr. Vu, I have one last question if we have a few minutes here. I hadn't heard previously about the concerns with the condom catheter. So I have a friend in town here who had his spinal cord injury 10 years ahead of mine. He's a complete C5, and he's been using condom catheter essentially 25 years. He's somebody who doesn't access the system much at all. So he's had really no follow-up. I don't really even know if he's had creatinines checked. Basically, if he's doing well, would there be any reason for him to change?
I think what you haven't told me is if he's had a sphincterotomy in order to use the condom catheter.
So I don't think so. When you mentioned that, that's a question I will ask him.
Yeah, and how many sphincterotomies has he had? Because it wouldn't be unusual. I would say like once or twice a year, I have this conversation with somebody who's an old timer, has been using condoms forever, and we talk them into getting a urodynamic study, and their detrusor pressures are 80. But they've just been living like that. Again, it's hard to say what the change is if they've been living at 80 for years. I don't know if the urologist or even myself would impress on them to change, but it's a very fine threshold, right? It's a slippery slope when that 80 becomes 100 and now you have hydronephrosis. So ask your friend if he's had a sphincterotomy. I'm curious.
Thank you.
Thank you, everyone, for coming to the Primary Care Spinal Cord Injury Lecture Series.